Now in this video we want to think about normal physiological observations in children. And we always need to assess the respiratory rate, the heart rate and the systolic blood pressure. These are three important parameters. And what I want to do is think about the normal values for a particular age, but then we want to think about why those values are as they are for that particular age of child, why they change with increasing age throughout childhood, and why these parameters are going to be different or somewhat different from the adult values that we would expect as normal. So here we start off with children of less than 1 year, with infants, 1 to 2 years of age, 2 to 5, 5 to 12 and greater than 12 years of age. And we want to think about respiratory rate first of all. So to begin with, let's just think about what is the normal rates. Now I can't put one figure in here because we always have a range, and the range here is 30 to 40. 30 to 40 breaths per minute in the infant, an infant being a child less than 1 year old. Now, young children breathe more with their diaphragms than with their ribs and intercostal muscles. Their breathing is often described as diaphragmatic. And for this reason, it's often easier to count the respiratory rate by watching the abdominal movements as the tummy goes up and down, rather than trying to watch the chest movements. So 1 to 2 years, normal figure there would be 25 to 35. 2 to 5 years, 25 to 30. 5 to 12 years, 20 to 25 breaths per minute. And greater than 12 years, we're getting onto the normal adult values, 15 to 20. The adult values would normally say are 12 to 20. So we see this pattern here of decreasing respiratory rate with increasing age. So it's decreasing as the age increases. So let's think about why this is. So what are the factors here in respiratory rate that can explain the differences that we notice with increasing age? Well, children are born with a small number of alveoli. So at birth, children will only have about 10 million alveoli across both lungs. And that's going to increase very significantly as we age. So the adult value is going to be about 300 to 500 million. So we're starting off with 10 million alveoli, the air sacs over which gaseous exchange takes place. And by the time we reach adulthood, that's gone from 10 million to an overall number over both lungs of 300 to 500 million. So we've got a massive increase in the number of alveoli. And the number of alveoli increase very significantly in the first few years of life, especially up until the time the child is about 8 years of age. There's a great increase in the number of alveoli. But even after this, the number of alveoli will carry on increasing through to adolescence, not reaching the adult value until adolescence. And the alveoli are what are responsible for the large internal surface area of the lungs for gaseous exchange. So again, we see in a newborn child, in young children, this is only about 3 square meters of internal surface area over which the gaseous exchange can take place in these air sacs, these alveolar air sacs. So if we open all these out onto a flat surface in children, it will only be 3 square meters over both lungs, whereas the adult value is 70 to 100 square meters over both lungs. So given there's a smaller surface area over which gaseous exchange can take place, it makes sense that the oxygen needs to go in quicker, and the carbon dioxide needs to go out quicker as well. So we're going to get adequate amounts of oxygen absorbed and adequate amounts of carbon dioxide excreted. So the number of alveoli increases throughout childhood. And as the number of alveoli increase, the internal surface area of the alveoli over which gaseous exchange takes place also increases. We see the respiratory rate decreases. So not only are the child's lungs getting bigger, they're getting more complicated in their structure, with more alveoli and more internal surface area. And as the child grows, they breathe less diaphragmatically. And that means that there's change in volume of the chest, which is attributable to contraction of the external intercostal muscles, pulling the ribs up and out to increase the volume of the chest via movements in the chest wall. That is much less so in younger children, who breathe much more diaphragmatically. In fact, a neonate, the chest is pretty well circular. But as we grow older, of course, the chest becomes broader in relation to its depth. So for the young child, the chest is almost circular. The chest wall doesn't work very efficiently. As we get older, it becomes broader relative to its depth. So in young children, there's less expansion from the ribs and the chest wall. But children have a very high metabolic rate. The basal metabolic rate in children is higher per kilogram of their body weight than it is for adults. So they have a high oxygen demand for their body weight anyway. They have a very high oxygen demand, metabolic demand. So again, this is going to decrease as the child gets older. So again, as the child gets older, the metabolic demand, therefore the oxygen demand, is going to decrease. And we see a consequent reduction in the respiratory rate. So there's some of the factors that explain the reduction in respiratory rate as the child grows and the lungs mature. So let's think next about changes in heart rate. So let's think about some figures first of all. So heart rate in young children under a year, we'll say 110 to 160 as being the normal range. They can be anywhere in that range and still be quite normal. 1 to 2 years, that's going to reduce a bit to 100 to 150 as being our normal range. 2 to 5 years, we'll say 95 to 140. Beats of the heart per minute. 5 to 12 years, we'll say 80 to 120. And then we'll say 60 to 100 for greater than 12, which indeed is what we say for a sinus rhythm in adults. So just as these were breaths per minute, these are contractions of the heart per minute. So what are the factors here in heart rate? Now, to explain this, it's just good to recap a little bit of basic physiology. The blood pressure equals the cardiac output times the systemic vascular resistance. So it's blood pressure that's necessary to perfuse the tissues of the body. And that's determined by cardiac output, the volume of the blood pumped out by the heart in a 1 minute period, multiplied by the resistance to that generated by the primarily the arterial vasculature, primarily the arterioles in fact. And the cardiac output itself is equal to heart rate multiplied by stroke volume. So the cardiac output is the volume of blood discharged by the, let's say, the left ventricle over a 1 minute period, and that equals the heart rate times the stroke volume, which is the volume of blood pumped out each time the heart contracts. And of course the cardiac output is going to be the same for the right side and the left side of the heart. So the cardiac output could be described as the output of the left ventricle into the systemic circulation, but the volume of the output from the right ventricle into the pulmonary circulation, of course, will be the same. So let's just bear those in mind a minute while we look at these factors. Now, stroke volume at birth is very low. The neonate has a relatively small heart, and the stroke volume at birth is only 1.5 mils per kilogram. So the stroke volume is relatively low. Now, if the stroke volume is low, but we still need to maintain a cardiac output, can you see the only way to do that is to have a faster heart rate? So we have to have a faster heart rate to maintain the cardiac output. And of course, we need the cardiac output to maintain the blood pressure to perfuse the tissues of the body with blood. Because that's the only way the body tissues are going to get oxygenated and going to get rid of the carbon dioxide from the waste carbon dioxide from the tissues. So because the stroke volume is low, the heart rate has to be high, and that's of course is exactly what we see in these figures. Now, at birth, the cardiac index is high. Now, the cardiac index is the relation between the cardiac output and the body surface area. So children need a high cardiac output in terms of mils of blood per minute per kilogram of the body weight. And this is because they have a very high metabolic demand. They need a lot of oxygen. So for their size, for their body surface area, they need a high amount of blood being outputted. That's the cardiac index. So just think of the cardiac index as the relationship between the cardiac output and the body surface area. So later on, for example, during adolescence, the cardiac index has dropped to about 100 mils per minute per kilogram. And the adult value is 70 to 80 mils per minute per kilogram. So we can see that also partly explains why the required heart rate is going to decrease with age, because of the relatively lower metabolic demands of the body in terms of metabolic demand or oxygen demand per kilogram of body weight, or relative to the surface area of the body. Now, as the child grows, the stroke volume will increase. So that's fairly obvious. As the heart gets bigger, it can have a bigger stroke volume. So a small heart is only going to pump out a small amount of blood per contraction. A larger heart can pump out a larger volume of blood. So the stroke volume is going to increase as the heart rate grows. And if the stroke volume increases, that means for a particular cardiac output, we require a lower heart rate, because more of the cardiac output is generated per cardiac contraction because of the increased stroke volume. So as the heart enlarges, stroke volume increases, cardiac output can be maintained, but the heart rate doesn't need to be as fast. And again, this is what we see. We see the reduction in the heart rate with increasing age of the child. And as the child ages, the heart muscle becomes stronger as it becomes bigger and thicker, and that increases the inotropic capacity. And greater inotropic capacity is also going to increase stroke volume. So inotropic capacity is how strenuously the heart muscle contracts. So it can contract more strenuously, generating a higher stroke volume as the child gets bigger. Because in infants, the stroke volume is relatively fixed. In young children, young children do not have an inotropic capacity. They have a low stroke volume, and it's relatively fixed. They can't increase it. So if you're 20 years old and you go for a jog, then your heart rate will increase, but also your stroke volume will increase. Children can't do that. They can't increase their stroke volume, especially younger children. And if they can't increase their stroke volume, then to maintain cardiac output, the only way they can do that is to increase their heart rate. This is why reductions in heart rate are so significant, especially in younger children, because they can't compensate with increased stroke volume. They don't have this inotropic reserve. They can't make the heart beat stronger. It can only beat faster. So if it's not beating fast enough, that means the cardiac output will drop. If the cardiac output will drop, the blood pressure will also drop, and that will reduce the perfusion of the tissues with oxygen, which of course is not a good situation. So always remember that any reduction in heart rate, especially in younger children, is a very significant finding, because they depend on their heart rate for their cardiac output. I mean, this is why children get fitter as they get older. The heart gets bigger, the stroke volume is going to increase, and the inotropic capacity is going to increase. So young children just run around for a few minutes and they get tired out. But as they get older, their exercise tolerance is going to increase. And I remember climbing high mountains when I was 11 or 12 years old, because by that time my stroke volume had increased, my inotropic capacity had increased, and therefore my aerobic capacity had increased, and I could exercise for longer periods of time. So just remember, in younger children, because they can't increase the stroke volume, their cardiac output depends on the heart rate. So any reduction in heart rate is a very serious clinical feature. But those things at least partly go some way to explaining why we have this reduction in heart rate as the child gets older. And let's think now about the systolic blood pressure. So first of all, again, let's put on some figures for what we would expect of systolic blood pressure. So up to a year, let's say 70 to 90 would be systolic blood pressure. Now, this is nothing to do with diastolic blood pressure. This is only systolic. 80 to 95 at 1 to 2 years. 2 to 5 years, 80 to 100. 5 to 12 years, we'll say 90 to 110. And greater than 12, getting towards the adult value, is 100 to 100 and 120. Now, as we've said, these are only the systolic pressures, because especially in emergency care, it's the systolic blood pressure that determines how well the tissues of the body are perfused. So we're not talking about the diastolic. So what we're saying here is in 5 to 12, the range of the blood pressure should be between 90 systolic and 110 systolic. We're not too interested at the moment in the diastolic figure. So why is this? Well, factors in systolic blood pressure. The body's bigger, therefore the pressure needs to be higher in order to perfuse all of the tissues, because there's more body tissues for it to go around. So it makes sense that we need that. But also we've noticed there's an increased inotropic capacity of the heart, so the heart can pump stronger. And that can increase blood pressure, because of course blood pressure's, as we know now, partly dependent on cardiac output. The greater inotropic effect will increase stroke volume, which will increase cardiac output, which can increase blood pressure. So the capacity of the heart to generate a stronger contraction is going to increase with increasing age. And also, as the child ages, there's an increase in the capacity to generate systemic vascular resistance. This is primarily at the level of the arterioles. So if there's a vasoconstriction, that's going to increase systemic vascular resistance, and that will increase blood pressure. If there's vasodilation, that will decrease systemic vascular resistance, and therefore decrease blood pressure. So in children, the systemic vascular resistance increases throughout childhood. And if the systemic vascular resistance increase in systemic vascular resistance, as we know, is going to increase blood pressure. But that's good, because we have a bigger body to perfuse with blood anyway. So that's exactly what we need. So if you're working with children, you need to memorise these figures really. What is normal for a particular age of child? Essential knowledge. But also what we've looked at helps us to understand why the respiratory rate, or the normal range of respiratory rates, goes down with increasing age. Why the normal range of heart rates goes down with increasing age. But why the normal range of systolic blood pressures is going to go up with increasing age.